Now we have closing remarks of Stephen Strasberg, please.
First of all, I'd like to thank Tadahiro Takata for his vision in making all of this happen 3 times. I think it's a great achievement. I really only want to say 2 things. The first thing is that populations are different in different countries in the world. In Japan, the population density is around 350 per square mile. No, I think 250 per square mile. In the United States, it's 33 per square mile. That means our population is much thinner and much spread out. And a lot of the laparoscopic cholecystectomies have to be done not by people who have had 10 years of minimally invasive experience and who've had special training, but by general surgeons who finish a residency and go into practice. And we must make, in the United States, we must make operation possible for those surgeons to do. So we mustn't give them instructions on how to do surgery that can only be done by people who are doing laparoscopic hepatectomies, because they'll never have that level of skill. So we have to take that into account. And I think learning how to bail out of a cholecystectomy is as important as learning how to do the cholecystectomy for surgeons like that. And I until about a year and a half or 2 years ago, I never did a bailout procedure in a cholecystectomy. I always operated until I could take the gallbladder out. But now I'm doing it frequently, so my residents learn how to do it, and so they're not ashamed to do it. They think, and on top of that, when you get down to it, the results, especially of a fenestrating cholecystectomy, are very, very good. A couple of weeks ago, I had a Whipple in which there was a small contracted gallbladder, and we had no idea that that this patient also had a small contracted gallbladder that was very, very badly inflamed. I actually did a subtotal fenestrating cholecystectomy and left it that way in a Whipple procedure because the right hepatic artery was running, an aberrant artery was running right behind the gallbladder. So what do I teach now about how you do a difficult cholecystectomy? I teach it in one word: don't. Don't. You don't need to. There's no reason to. The patients do just as well in the long term if you don't do it and if you bail out. And the reason that the critical view of safety works, in my opinion, in these circumstances is that it's more difficult than other techniques, and so people stop and they bail out and they don't cause an injury. Now, there's something I want to say about this last flow chart, which I think is important in that regard. We have to be careful in amending the guidelines that a level of strength be given to the recommendations. The strength, of course, should depend upon the quality of the evidence. With grade 3, based on the new evidence, suggests that early operations in patients without predictive signs is okay. But there's not a great deal of evidence, there's not a great deal of information about these grade 3 patients. So we're saying it's okay if a patient who has single organ system failure, cardiac or renal, it's okay to take them to the operating room. I think we have to be careful about that. I think what is happening here is that patients come to the hospital, they have single organ system failure, cardiac or renal, but it's because they're septic. And they go to the ICU, and after a few hours, they're no longer grade 3 because they get fluids, they get antibiotics, and their level changes from grade 3 to grade 2 or grade 1. I think it's fine to take those people to the operating room. But what if a person is grade 3 because they have underlying cardiac disease or they have underlying renal disease? So I think we have to be very careful in the narrative portion of the papers that we make it clear that we don't have all the information, and our recommendation should not be a strong recommendation. It should be a moderate recommendation for those patients. Again, thank you very much, and I think it's been a great session.